Okay. Okay, so this week it's respiratory and cardiac. So it's a lot of material, okay? And I know that. But this is all very important things to know because usually if you're going to have troubles with a kiddo like crashing or getting really, really ill, it's usually related to a respiratory cause or a cardiac cause, okay? So it's really important that you guys, as nurses, know how to handle a kiddo with a respiratory disorder and also if they end up having a cardiac disorder. Okay, so respiratory physiology, ventilation, that's the process of breathing air in and out, right? So involves the intercostal muscles, so those muscles between the ribs. It involves the diaphragm, the ribs themselves, the brain, and then multiple chemoreceptors, right, to kind of cue that body based off the amount of oxygen and the amount of CO2 return to be breathing in and out. Red blood cells, that's what carries your oxygen to your lungs and, or excuse me, to the tissues and your CO2 to your lungs, okay? So if you're anemic, so if you don't have a lot of erythrocytes or red blood cells in your body, you're naturally going to have less oxygenation in your tissues. Doesn't necessarily mean you're going to have like a low oxygen saturation from that, but it is not uncommon to see that potentially. And your normal respiratory rate values are there. And obviously, oxygenation wise, you should have a pulse ox of greater than 90%. I will say on kiddos, sometimes it's tough to get a consistent reading on your pulse ox machines. If they're moving around, if they're crying, if they're fussing, you guys have to take that into consideration, okay? Because it's not going to be, you're not going to have a good, reliable waveform on those. Respiratory distress, kids progress very quickly from respiratory distress to respiratory failure because they can only compensate for so long and then they, are unable to compensate. So if you're noticing accessory muscle use, such as like subcostal or intercostal retractions, so that's sucking in between the ribs or under the rib cage, tracheal tugging, so the trachea, you'll actually kind of see this area of their necks kind of move. So if you are starting to notice that, they're starting to become more tachypnic, so they're breathing faster than they should be, or they're having any abnormal lung sounds, it would be really important to be letting that provider know. So your pulse ox numbers are going to be one of the last things that drop. So if you're putting a pulse ox and that kiddo's just laying there and it's already at, 80%, then you should be really, really concerned that that kiddo is going to progress very quickly to respiratory failure. Okay. So obviously in respiratory distress, there's different forms of oxygen that we can do. We can do a nasal cannula if that's going to help maintain their work of breathing. And you can go up to 6 liters on nasal cannula. Okay. There's also the non-rebreather bags. Those have to be at 10 or 15, depending on the type of bag that it is. Okay. Also in kids, we'll do a lot of high flow oxygenation. So that allows them to get some pressure in their lungs as well as getting that oxygen to kind of help get them some PEEP. You guys may have heard of PEEP, like with ventilators, but we can do that with the high flow machines too. Of course, there's always CPAP and BiPAP too with kids before we intubate them. Okay. Respiratory monitoring, obviously you guys will be doing that along with a full set of vitals more routinely, but you want to look at their work of breathing as well. So, are they retracting? Are they looking cyanotic around their lips? Are they, becoming tachypnic? Are they having abnormal breath sounds? Okay, so that's all a part of your nursing assessment. Okay, so nasopharyngitis. So this is inflammation of your nasal passages and your pharynx, so in the back of your throat. Coryza is a term just for common cold. Okay, so coryza, common cold, if you see that in an exam or in a question somewhere, means the same thing. Allergic rhinitis, so this is inflammation due to allergies. So, you'll see inflammation, allergies causing watery, itchy eyes, nasal congestion, runny nose, dark circles under their eyes called allergic shiners. So those are all kind of suggestive causes of allergic rhinitis. URI, or an upper respiratory tract infection, that can be caused from a variety of different viral illnesses, typically in kids. You don't see kids get a lot of like true sinus infections like you see in adults. And that's simply because their sinus passages are so small. So fever management wise, you want to manage fevers in kids. If kids, this is usually what I tell parents, if kids are acting okay and they have a bit of a fever and they don't have a history of febrile seizures, you can kind of see what that fever does. But if they're, not drinking, they're not acting like themselves, and they're seeming really bothered by the fever, then definitely treat that fever. If kids have fevers, they're more likely to progress more quickly to dehydration. And that's one of the biggest struggles with kids with URIs is they don't feel well, so they don't want to drink. Or they're struggling to breathe and they don't want to drink. Okay. Acute pharyngitis, so that can be caused from viral illness, but also what do we think of most commonly? Strep throat, right? That's the bacterial form, group A strep, okay? So if kids test positive for strep throat, they need an antibiotic, because if they're not treated with an antibiotic, then there can be a lot of serious complications from group A strep in the form of rheumatic fever, so they can have joint pain, joint inflammation, redness, swelling of multiple joint spaces, glomerular nephritis, so they can have effects on their kidneys. They can get peritonsillar abscess from strep, which can obviously affect their breathing. Ear infections, otitis media, mastoiditis. So your mastoid bone is your bone right back behind your ear. So that can actually become red and inflamed from strep throat as well. Meningitis can happen from strep throat. Osteomyelitis, which is infection in the bones, okay? And pneumonia can also be a cause from strep throat. So if strep throat is missed, it's very risky for those kiddos. So be extra vigilant with sore throats and checking. Also with strep throat, sometimes kids have they won't say that they have a sore throat per se, but they may have like upset stomach, body aches, throwing up, and that strep can come about from that. The other piece with strep is they can have scarlatina, which is also called scarlet fever. So that's a red raised, bumpy rash that they'll get with strep. It's almost like if you feel the rash itself, it'll feel kind of like sandpaper. So if you have a kiddo that has a rash like that, it'd be pretty important to make sure that they're tested for strep. Okay, sinusitis. So this is, like I said, not a lot of kids get sinus infections, but if they do have sinusitis or a sinus infection, they require antibiotics for that to resolve. So the actual definition of sinusitis is they have like a viral illness or a cold for a few days with a lot of nasal congestion, and then it starts to get better, and then they start having fever and that facial pain and headache, okay? So that's kind of your clues that they may be having sinusitis. Croup is also called laryngotracheobronchitis, okay? So that's the same thing. That word is typed out on your PowerPoint, okay? But croup and laryngotracheobronchitis, same thing. So if you see either one of those words, they're talking about croup, okay? Croup is that tight, barking like a seal cough, okay? So these kids really sound like they're a seal when they cough, okay? And that's because there is narrowing in the upper airways, okay? So there's some restrictions in those upper airways. So that's how you get that noise. You also get the inspiratory stridor. So when they're breathing in, they're like, that's kind of how they're going to sound. They don't always sound that way with croup, but that's pretty classic. Okay. Now, if you live somewhere cold, that parent goes to take that kiddo outside to take them to the hospital or take them to urgent care or the clinic, that noise, that'll get better when they're outside in the cold because it helps decrease that inflammation. So if they're crying, if they're agitated with any respiratory stuff, obviously their respiratory status is going to look worse, okay? But you're going to hear more stridor, okay? So treatment for croup, it's typically something that happens after a virus, so there's not an antibiotic for it. However, there are steroids that you can do for it. There's also inhaled epinephrine, so racemic epi is something that you'll see providers do for kids who are pretty sick with croup. If kids are doing okay with croup, then parents can try to manage them at home with cold mist humidification. Okay. But the big thing with kids who are already in respiratory distress is you really don't want to use opiates or anything that can sedate them further and decrease their respiratory drive. Okay. So that's that noise. Okay. So that's what a kid with croup sounds like. Did you guys all hear that, or do you want me to play it again?
We heard it.
Okay, perfect. Okay, so epiglottitis. If this is happening, this is an emergency. This kiddo needs to go to the ER. They're going to need intubated as quickly as possible, okay? So this is inflammation of the epiglottis. So there's swelling of the epiglottis that's starting to swell enough that they're going to no longer have an airway. Typically caused from Haemophilus influenza. Now, we give vaccines for Haemophilus influenza. That's the Hib vaccine. Okay. So we have seen a reduction in this epiglottitis, but now with parents maybe being more cautious with vaccinating their kiddos, we have seen some increase in epiglottitis because they're not getting routine vaccines any further. Okay. Like I said, it's straight to the ER. It's life-threatening, very rapid onset. Okay. You will see these kids kind of tripoding. So they're trying to lean forward. So they'll put their arms out in front of them and kind of lean forward to try and get as much air in as they can. They're excessively drooling because they can't swallow their drool as well because of that inflammation. Okay. The other thing you might notice is that they're not coughing. Okay. So if you have a kid coming in that's drooling and they've not been coughing and they're just working, like trying to get in any position to get some air down their trachea, then that would be something really concerning that you'll have to be grabbing that provider really quick. Okay. You don't want to try to look, like use a tongue blade to look down the back of their throat, because that can also worsen the laryngospasm that happens. Like your gag reflex that happens can worsen the swelling. Okay. And like I said, these kids are going to need intubated very quickly. So make sure you have an intubation kit at the bedside and also a trach kit. Because if they can't intubate them to set up their airway, then they'll have to put in a temporary tracheostomy tube. Okay. Okay, bronchitis. So this is a not productive hacking cough. Okay. Cough suppressants, it says in your book you can still utilize them. The American Academy of Pediatrics has really gone away from suggesting cough suppressants. First, because there's not a lot of benefit in them. And second, because of the potential risk of the differences of dosing. So like some of them are for 4-hour dosing, some of them are 8-hour dosing, some of them are 12-hour dosing. And a lot of times you'll see parents get confused and maybe be, giving kids multiple doses throughout the day of the 12-hour dosing versus the 4-hour dosing. So you see some overdose from cough medicine. Okay. One thing that's really helpful for cough, if the kiddo is over a year of age, is honey. They can do a teaspoon of honey. Okay. Okay, so bronchiolitis is inflammation of the bronchioles, which are the tiny airways in the lungs. Okay, so you'll see bronchitis, that's kind of more of the inflammation of the bronchi, whereas bronchiolitis is more common in kids, and that's the inflammation of the bronchioles, so those tiny airways. Bronchiolitis, you get really concerned about, like the risk for admission being really increased between 6 months to 2 years of age. Most common cause of bronchiolitis is RSV. Okay, so respiratory syncytial virus, or RSV. That's what you see most commonly causing those little teeny airways, those little bronchioles to get really gunked up with a lot of mucus, and then your lungs can't function as well. Okay. We now have an RSV preventative monoclonal antibody vaccine. So actually this year I've seen a lot less RSV severe, like a lot less severe RSV than there have been in the past years. And kids can get that their first season, RSV season. And it's just a one-time dose. In your book, you probably saw something called Synagist, which is another preventative RSV vaccine. But with that vaccine, only high risk, like premature kiddos can get that vaccine. And they have to come in once a month during respiratory season for that vaccine. So that's why this new Fortis is the brand name, which you guys won't have to know that, but that's why this new one is really helpful, because it's just a one-time dose and it covers them for the whole respiratory season. Okay. RSV is also one of the most common causes of viral pneumonia in kids less than 2. Okay. Because it's viral pneumonia, you don't always have to treat with antibiotics. But if there's any question that it's a bacterial cause of pneumonia, then they'll need treated with antibiotics. Tonsillitis and adenoiditis. So tonsillitis is inflammation of your tonsils. Adenoiditis is inflammation of your adenoids. So you'll see kids with tonsillitis. There can be viral tonsillitis. There's also tonsillitis from strep. Okay. So if kids have a lot of strep and a lot of troubles with strep throat, then those kids need to have their tonsils taken out. Okay. So if kids have a tonsillectomy or an adenoidectomy or both, you see kids swallowing a lot, then you really want to get concerned that that kiddo is bleeding. after having their tonsils removed. Okay. Obviously, having them follow a soft diet or a liquid diet hopefully helps to reduce those scabs to come off of those tonsil beds. But one of the most common causes after a tonsillectomy is, or one of the most common things is bleeding actually after a tonsillectomy. That's why they don't do them quite as routinely as they used to. Okay. And kids can bleed very, very fast or very significantly with tonsil post TNA. Okay. The other thing too is making sure that they're not drinking a lot of milk products, because that can kind of coat those tonsil beds and then cause those kids to clear their throat a lot. And then that continues to irritate that operative site further, and those scabs kind of on those tonsil beds. So try to stay away from milk products. Okay, popsicles, juices, things like that. Okay. The other thing too, after a tonsillectomy and adenoidectomy, it is not uncommon at all to see kids not want to drink because of the pain. So you want to make sure and educate the parents to have, around the clock pain medicine, even if their kiddos seeming to act okay, especially for the first few days. So that way they can continue to drink and have good wet diapers. Okay, or be going to the bathroom appropriately. Okay, asthma. This is probably the most common respiratory disorder that most all of us know someone with asthma, or have maybe cared for someone with asthma. So this is an obstruction during expiration. So they can have some obstruction during inspiration, but it's most significant during expiration. So when they're exhaling. Okay. So you'll see kids coughing, wheezing, expiratory wheezes mostly. Okay. Difficulty getting air in. So they feel like they can't get enough air in. So you'll see kids go potentially into respiratory distress. So nasal flaring, using their accessory muscles. They may also have breathing rate changes with position changes. Okay. It's the number one cause of school absenteeism. Okay. It's the number one cause of ER visits and hospitalization of kids. Okay. Status asthmaticus means that they continue to have severe respiratory distress and they didn't respond to their typical treatments. Okay, so that's a medical emergency. They need to be in the ER. Okay. Typical treatments for asthma are going to include inhalers. So there's short-acting inhalers, there's long-acting inhalers. So your short-acting are more like your rescue inhalers, so albuterol. Okay. Your long-acting inhalers are going to be something like Pulmicort, so budesonide. So that's going to have a steroid as well as a quick-acting. Okay. You can also see kids need steroids when they're having an asthma flare-up from one of their viral illnesses. Okay. And eventually they may, if they continue into status asthmaticus, they may need racemic epi or IM epi. Okay. Okay. Cystic fibrosis. So it's in the respiratory category, but it affects many different body systems. Okay. So your respiratory system is affected because of the thick, viscous secretions that happen with cystic fibrosis. They start to accumulate in those alveoli and they can't keep their lungs open and functioning as well because of those thick secretions. It affects the digestive system because it prevents those digestive enzymes from going into the GI tract and absorbing the nutrients like it should. Okay. You will see kids with cystic fibrosis will have foul smelling, really bulky statorrhea stools, so fat, mostly fat containing stools. Okay, because they can't digest that fat. Okay, their skin will be affected. They're going to sweat out their chloride. So they're going to have salty skin. So they're going to have effects on their electrolytes. And their reproductive system's also going to be affected. So boys, males, will have infertility troubles. And they'll continue to have those until they potentially have a double lung transplant and have had that lung transplant and been on anti-rejection meds for a year. And then they should be able to have children after that. But until that point, because of those thick secretions, sperm motility is really affected. So they will not be fertile. Women also can have some reproductive effects, but it's not as significant as the man. They're not considered totally infertile. Okay. So diets for these kids should be high in sodium and protein. Okay. They should not be eating a ton of fat because they can't digest the fat anyways. And it just worsens those steatorrhea stools. Okay. They're going to be taking pancreatic enzymes with their food to make sure they're absorbing all those appropriate nutrients. Okay. They need rest. They need prevention of respiratory infections specifically, and adherence to their medication protocols. A lot of times these kids are going to be on inhalers, steroids. They're going to have chest physiotherapy or chest, you'll see CPT. So that's when they put on a vest and it kind of vibrates and breaks up that thick, those thick secretions in their lungs. So they'll be doing that typically as well. And it is a chronic disease. So they'll be in and out of the hospital, unfortunately. So they'll need a lot of support. Okay, BPD or brachiopulmonary dysplasia. This is thickening of the alveolar walls and the bronchiolar epithelium. You see BPD most commonly in premature infants. Okay. SIDS or sudden infant death syndrome. That is a sudden, unexpected death in a kiddo 2 weeks to 1 year of age. The risk potentially peaks the highest between 2 to 4 months. Boys are more at risk than girls for SIDS. Obviously, if parents are smokers or that baby has exposure to smoke exposure, that's a more risk factor. Being more premature is also a more risk factor for SIDS. Co-sleeping, so sleeping with parents, things being in the crib, so them having stuffed animals or those bumper rails, which I think most of us know not to put a bunch of stuff in babies' cribs, but those things can all still be risky. And putting that baby on their back to sleep helps decrease the risk. Okay, kind of flew through the respiratory stuff, but any questions before we start cardiac? No? Okay, so remember from your maternity, the cardiac system is the very first system to be fully developed in kids in utero, okay? So it starts very, very early on. There's a variety of different congenital heart disease. So this is caused from a genetic cause or potentially something that mom was exposed to while in utero or an infection that mom had while baby was in utero. Okay, so this is where you see these congenital heart defects start. You don't see the effects of the congenital heart defects while baby is in utero because of the way that the fetal maternal circulation system is set up. You start to see this after birth when those PDAs and things close. Okay. Like I said, at birth, there has to be that transition period of the infant circulatory system from mom's, the maternal fetal, to child's, okay, to be able to continue to provide those infants with their oxygen needs. Okay. Some signs that would make you suspicious of a cardiac pathology or congenital heart defect would be kiddos who are not gaining weight appropriately, so their failure to thrive. They have cyanosis. Okay, remember some cyanosis of the hands, agrocyanosis, the hands and the feet shortly after birth is normal, but that should resolve within a couple days after birth. But if we're noticing cyanosis or paleness around the mouth or the central body, so like trunk, neck, then that would be more suggestive of a cardiac defect. If you're seeing that pulsation of the neck veins, okay, just like in adults, that's more suggestive of a cardiac defect. Working harder to breathe, having a quicker pulse, irregularity in their pulse rate, clubbing of the fingers. Now this takes some time. So that's like where the fingernails get really thick and rounded. But that takes some time of cyanosis for that to start to happen. Fatigue with feeding, they're sweating with feeding, they're really working hard to feed, and they're having to take frequent breaks. Also, kids who have frequent respiratory infections, like you can't figure out, they're just always getting respiratory infections, and they're working really hard to breathe, and they're working really hard to eat. That might also be suggestive of a congenital heart defect. So nursing care and treatment of kids with CHD or congenital heart disease, you're going to obviously these kids are going to be on continuous cardiac monitoring. So they're going to have their telemetry on. You're going to monitor them for signs of respiratory distress and cyanosis. So if you start to notice any increased work of breathing in cardiac kids, you really need to be letting your provider know. An aortogram is a test that they utilize x-rays to look at the aorta after they inject it with a dye. Okay, so that looks at the function of the aorta. An electrocardiogram or an EKG or ECG that looks at the electrical function of the heart. Okay, and it's showing you the condition of the heart muscle and when it's pumping. Okay, angiocardiogram, so that's going to be pictures under fluoroscopy. So they're using ultrasound. They're going in typically through their femur area or their radial site, and they're looking with the camera at all of the veins and arteries in the heart. An echocardiogram, so that uses ultrasound. So this is external ultrasound, okay? And that looks at murmurs and potentially structural abnormalities that they can visualize, like so of the valves or holes in the heart, things like that, okay? Kids with congenital heart disease typically have to avoid competitive sports. They're going to need really strict nutritional guidance depending on their defect. And they also need to be careful in really cold environments and really high altitudes, just because in those environments, your oxygenation is not as good as it should be naturally, because you're at a higher altitude, so your body has to work harder. So ideally, these kids should try to avoid those high altitude areas, especially if they're not from an area like Colorado or, Montana, where they have the mountains where it's more high altitude anyways. Okay. So two types of defects. There's cyanotic lesions and acyanotic lesions. So cyanotic lesions are going to be your blue babies. Okay. This is when their oxygenation is affected. Okay. Acyanotic, their oxygenation is not affected. Okay. So increased pulmonary blood flow, that's going to be your ASD, so your atrial septal defect, your ventricular septal defect, your VSD, and your PDA. Okay. The obstruction of blood flow or narrowing. So coarctation is a narrowing. Okay. So coarctation of the aorta, there's going to be an obstruction because there's going to be just a small area, a smaller space for that blood to get through. Decreased pulmonary blood flow. So this is going to be your cyanotic lesion. So your increased pulmonary blood flow on this slide, your ASD, your VSD, your PDA are going to be your acyanotic lesions. Okay. Because those force the blood to circulate more often to the lungs. Your decreased pulmonary blood flow are going to be your acyanotic lesions. Okay. Or excuse me, your cyanotic lesions. I said that wrong. Decreased pulmonary blood flow. So your tetralogy of Fallot, your hypoplastic left heart, and your truncus arteriosus. Those are all going to be cyanotic lesions. Okay. A shunt refers to the blood going from the typical opening to the abnormal opening. Okay. Blood will always go from a high pressure area to low pressure. So which side of the heart usually has high pressure? Where's the highest pressure in the heart? Typically.
The right side.
Right side or left side?
Left.
Yes. Why?
Because it's
that,
starting there?
No, because that's what's pushing it to the body, right?
Because because it starts in the right side and it pushes it to the left, like right at the top, right?
Well, it goes in the right atria, right? Through down to the right ventricle, out to the lungs, comes back from the lungs, into the left atria, left ventricle, and then out to the body. So your left side of your heart, your left side is going to have the most pressure. So if there's an opening in either atria, so you have an ASD, or you have a VSD, so the opening between the septum, so between the wall of the two atria or the two ventricles, that blood is going to want to go from the left side to the right side because there's less pressure on the right side. Because your heart doesn't have to work as hard to pump it to your lungs as it does to your whole body. Does that make sense? That's why your VSD, your ASD, and your patent ductus arteriosus or your PDA, those are going to circulate, that blood's going to shunt from the left side to the right side, and it's going to circulate more of that blood to the lungs before it pumps it out to the body. That is why those are acyanotic lesions. Okay. So the blood's always going to try and go the path of least resistance. So from left to right. Okay. Okay, ASD. So here, you can see on the picture here, typically there's no opening here. So your blood's going to come in from your SVC, your superior vena cava, into your right atria, through your tricuspid valve, to your right ventricle, out to the lungs, okay, and then back in to the left atria, through your mitral valve, through your left ventricle, and then out to the body through your aorta. Okay, that's normal. Now, when you have an opening in your atria, so an ASD, the blood's going to try and come from the left side, right? Because we decided the left side has more pressure, over to the right side. So then you're going to get your mixing your purple blood here. because it's going to continue to circulate back to the lungs more often before it goes to the body. Okay. The treatment for this is closure. So they do a little patch. They typically can do that in a cardiac cath lab. So just through, like I said, the femoral area or the radial area. Okay. Questions on ASD?
I want to verify something. With
Uh-huh.
the cyanotic and the acyanotic, just so that I'm getting it correct, the acyanotic is just the irregular flow of blood, right? So the irregular flow of blood. And then
Acyanotic is increased blood flow to the lungs.
Oh,
Because
increase.
they are not cyanotic. Those kids are not having cyanosis because that blood keeps circulating to the lungs.
Okay.
Cyanotic lesions, these kids are going to have cyanosis. So this is going to be your blue babies because the blood is not circulating like it should to the lungs.
Okay.
Does that make sense?
Yes.
The naming of them is kind of confusing. Like as far as cyanotic versus acyanotic, but that's the easiest way that I can think to teach you guys.
Okay.
And if you have questions, you guys can reach out too. Any other questions on ASD before we move on? No. Okay. VSD, very similar to ASD. Okay. Still more pressure to the lungs. Okay, still more blood flow to the lungs. This is just an opening in the septal wall between the two ventricles. So you can see that here. So the blood's going to go once again from the left side to the right side because there's less pressure on the right side than there is left. So the blood's going to shunt through that opening to the right ventricle. Then it's going to circulate to the lungs again. Okay, before it goes to the body. Once again, cath closure. Sometimes they have to have more of an open surgery to fix VSDs. Okay, your PDA. So this is something that you have to have, the baby has to have to continue for fetal life. Okay, so that means when they go through that transition at birth, this PDA stays open. Okay, it should close because they no longer need it once they're out of mom's belly. Okay. If it doesn't close, there's one thing that they can try, and that's indomethacin. So that is an NSAID. So that's an anti-inflammatory that they can give kiddos to try and close that PDA. Now, in some cases, kids will have a PDA, but also another cardiac defect. And they have to leave that PDA open for that kiddo to continue to have good oxygenation. So they will not give those kids indomethacin. But if kids just have a PDA, then they get indomethacin first to try and get that hole to close. Okay. And you can see right here, here's your PDA. So it's a connection between the aorta and the pulmonary vessels. Okay. That's how it overrides, circulating to the lungs and to the body in baby. Okay, when they're in utero. Monitoring blood pressure is really important in these kids, well, in any cardiac defect kiddo, but especially in PDA kids, because they can have significant changes in their blood pressure. If the indomethacin doesn't work, then they have to have that opening closed with either cardiac cath or surgery. Okay. Here is, okay, hopefully you guys can see this. Can you see this okay? Okay, I'm going to start it.
Coarctation of the aorta. Coarctation. It's a fancy word for restriction. Coarctation of the aorta. So, like I said, it's a restriction of the aorta. It looks like this. So instead of our nice big aorta that we had before, in this case, the aorta comes down here and whoop, there's a little coarc there, right there. Actually, it could be anywhere, but that's one of the most common places to have it. So then the rest of it goes on. So this little squeeze here creates a lot of resistance. Because there's a lot of blood flowing through the aorta at any second. And to have this bottleneck here creates a lot of resistance, which again increases the pressure. So now we have the left side having even more pressure than before. And coarctation can be its own isolated defect, but sometimes it also involves a VSD, ventricular septal defect. That just means a hole between the two ventricles. So here we have our VSD.
Okay, so that's a quick video. So essentially coarctation, it's just a fancy word for narrowing. So what do you think? So if you kink off a hose, what happens back behind where you've kinked it off? That
The back
Pressure builds up.
Yeah, that pressure builds up, right? And then you unkink it and it shoots really far. So with coarctation, these are also going to be, this is also acyanotic, okay? Because it's going to build up, that pressure in the left. I will say it's almost always with a VSD or an ASD, but that's not a given rule, okay? So if the blood has somewhere to back up and shunt to the right side, it's going to shunt to the right side and go through the pulmonary arteries to the lungs more often. But your biggest thing is going to be that narrowing is going to cause a lot of resistance. Okay.
Coarctation of the
Oh, sorry. Okay. So this is diagnosed using that arteriogram. Okay, so with that x-ray and that dye. You're going to have higher blood pressure in the upper extremities and lower blood pressure in the lower extremities. That's going to be your sign that maybe that kiddo has a coarctation. Okay. If it's left untreated, then they're going to progress to congestive heart failure. They're going to have high blood pressure, and they may even get infective endocarditis, so an infection in their endocardial lining. Okay. Okay. Tetralogy of Fallot. I'm going to keep going. You guys can, you can leave class technically at 35 since we took that little break between.
Tetralogy of Fallot. Don't worry about what Fallot means. That's just the name of the guy, this French physician who named this disease. So we want to focus on the first word here, which is tetralogy. And going back to Latin here, tetralogy, the word is telling us that there are 4 defects that we care about that make up this particular heart disease. Remember that this is congenital, so people are born with these 4 defects in the heart. But first, let's quickly review what a normal heart does. So blood from the body that returns to the heart initially is going to be blue because it's low in oxygen. The muscles have used up the oxygen. So it returns to the heart into the right atrium, the receiving chamber. From there, it goes to the right ventricle, which pumps it into this blue vessel, which is the pulmonary artery. Remember that any vessel that receives blood going out of the heart is an artery. So even though it's an artery, it's still blue deoxygenated blood. From the lungs, red oxygenated blood returns here via the pulmonary veins into the left atrium. There it goes to the left ventricle, and it goes out this big red structure, the aorta, to the body. So in tetralogy, the first defect that we worry about, some would argue it's the defect that governs how this heart functions, is called pulmonary stenosis. So pulmonary, it has to do with the lungs. In this case, it's referring to the valve that leads blood to the lungs. So the pulmonary valve is right here. Stenosis is a stricture, a narrowing. So this pulmonary valve here is thickened. See, as the right ventricle is pumping blood into it, it is harder to pass through because it's literally just thick and restricting. So the degree of pulmonary stenosis determines how hard is it to pump blood into the pulmonary arteries. It determines how severe this heart is functionally damaged. Now, our second defect is a direct result of this and also depends on the degree of stenosis, and that is right ventricular hypertrophy. So imagine trying to pump blood against a narrow opening day in and day out. Hypertrophy is when the muscle is overexercised and overused, and it literally becomes bigger. So the right ventricle, this chamber right here, becomes thicker, just from the extra workload that it has for pumping against this narrow valve. So a lot of times this hypertrophy is enough to alter the shape of this right ventricle here. So do you see in the way I've drawn it before, it has this nice slope? So if our normal heart follows a curvature kind of like this, in tetralogy, the shape can actually look more like this. It comes down here, right angle. And that's why some people actually say on x-ray, when just looking at the gross shape of the heart, can look like a boot. So the boot sign is something that we associate with tetralogy because of the severe right ventricle hypertrophy that can happen. All right, let's move on to the third one. So usually there is a hole between the right and left ventricle, the bottom chambers. Draw this hole right here. It can actually be anywhere along the septum, and we call it a VSD, which stands for ventricular. It tells you where it is. It's between the ventricles. Septal, which is the wall, the septum between them. Defect, you have a hole. Okay, I'm going to draw this right here. So now in the machinery of the heart, we have a connection between the left and right. And now for the last defect, we have an overriding aorta. What is the overriding? So the aorta is usually plugged into the left ventricle, but overriding means that it actually receives blood from both left and right now. And from the place I've drawn this VSD right under the aorta, I could almost just leave it like this, but just to drive the point home, I want to redraw this part, that the aorta comes over to the right, and it's now this kind of central structure. Now from here, now it can receive blood both from the right and left. So now let's think about if I'm a drop of blood, where I want to go in this new heart with these 4 defects. So from the right atrium, go to the right ventricle, that's normal. So from here, I have a choice, right? I can either go up this pulmonary artery through this very narrow opening in the valve. That's going to be difficult. Or I can easily go into this aorta with a valve that's more welcoming, that's less restricted. So I draw these 2 arrows with different calibers, because I'm leading you to the answer, which is that I want to go this way into the aorta. Also, in general, blood in the right ventricle is going to be pushed toward the left, because look at how big the right ventricle is now. It's this huge, powerful muscle, and it serves as the motor that drives this right to left shunt. And therein you have the answer for why this is a cyanotic disease, because blue blood is being forced to the left because A, it's hard to go through the pulmonary artery where it's supposed to go, and B, the right ventricle is so powerful it's going to push it across the VSD. Remember, blood follows the easiest path. So the left ventricle is still pumping, and the blood is basically going to go into the aorta. So now in the aorta going out to the body, we have red blood and we have blue blood. So what actually goes out to oxygenate our body is this purplish mixture. Purple, some blue, some red. And at any given moment, how blue it is or how red depends on the tug of war between all these factors. How restricted is this pulmonary artery? How much resistance is coming from the lungs? Remember, the pulmonary arteries are plugged into the lungs. How hard the right ventricle is pumping blood across the VSD. So these are all factors that determine how much our purplish mixture is red versus blue. Sometimes kids who have tetralogy can have a sudden tet spell, which is when they get acutely worse and they can't breathe. That's because their pulmonary artery pressure or resistance from the lungs has suddenly increased. All that does is create more back pressure in the pulmonary artery. It's already hard to get blood in here, and the tet spell makes it even worse. So a tet spell shunts more blue blood into the aorta. This mixture becomes even bluer. This is a life-threatening emergency in tetralogy. And lastly, I also want to talk about the fact that before people even knew what tetralogy was or what the heart actually looked like, we noticed that kids who have it, or this type of kid, would suddenly squat onto the ground, especially when they've been playing or running around. They'll suddenly feel a lot worse. They'll squat and they'll feel better. So here we have a kid. I always say kid because for the most part, this is still a pediatric disease. We correct it in the patients when they're kids. So they're running around, let's say they're 4 years old, and suddenly they'll stop and they'll squat onto the ground. How do you draw a squatting stick figure? Does that make sense? That looks more like they're sitting. Let me try again. So they're squatting. There we go. And as they get into this position for a few seconds, they feel better. So let's think through this step by step. Okay, 2 things happen when somebody with tetralogy, or I guess anybody, is running around. The first one is that the O2, or oxygen saturation in their veins, drops because their muscles are working hard and they're extracting more oxygen from it. So the blood going back to the heart here and here have a lower oxygen content. And secondly, what happens is that their vessels in their legs, or whatever muscles they're using a lot, they vasodilate so the body can get more blood there. Literally, the vessels in their blood, the diameter goes from this to this. It just gets bigger. So let's look at this one at a time. So if the O2 in the veins drop, what happens? So the blood returning to the heart is essentially bluer. So if the blood returning to the heart has a lower oxygen concentration, and some of it goes right back out to the aorta, then running around has made our blood bluer in the aorta. All this does is make our cyanosis worse. That's going to make our patient more blue in the face, and they don't feel good. For vasodilation, what happens is the structure or the caliber of the vessels determines how much resistance is pushing back on our aorta. So the vasodilation really lowers the resistance in the aorta. So in the competition between the right and left, between the blue and the red, again, this makes us bluer, making this red structure have lower resistance, means more of the blue blood will get into it. So again, we're bluer and more cyanotic. So now this child is really not feeling well. And look, when they squat, both of these things are reversed. First of all, they stopped running around, so the oxygen content in their veins can go up. So here they've got slightly higher oxygen content in their veins just by stopping and trying to take deeper breath. And secondly, they're literally taking the vessels in their legs and squeezing them, which increases their systemic resistance. This is the resistance of all the arteries in the body, systemic resistance. And since they're all connected to the aorta, this increases the resistance that the aorta is pumping against. So as these 2 colors of blood rush at this general area, when the resistance in the aorta increases, it literally just forces more blood into the pulmonary artery. So the competition is where is it harder to go? And when this child has squatted, it is harder to go into the aorta at this point because it's like they've taken the end of a hose and they've squeezed it down. So this just forces more blood into the pulmonary artery. It's still restricted, but it's not, the difference between the 2 has lessened. So more blood goes into the pulmonary artery. This child will feel like it's easier to take some good breaths. And this will also increase the return of oxygenated blood into the left side of the heart. So the whole effect is that we reverse the shunt a little bit. We get more blood out to the lungs, the pulmonary artery, and we just increase the overall oxygen content in our mixture a little bit. So when we think of tetralogy, the things that most determine how bad or how severe a person's symptoms are, 1, the pulmonary stenosis, how severe is it? And 2, where is the BSD? So I would think of tetralogy overall as a constant fight, a tug of war for the heart to pump blood into either the pulmonary artery or the aorta. And the state of the mixture between the red and blue blood determines this person's symptoms at any given moment.
Okay. So there's 4 defects in tetralogy of flow. Okay. Your VSD, pulmonary stenosis, your overriding aorta, and then that right ventricular thickened muscle hypertrophy. Okay. So there's kind of a lot in this one. I will say this is the defect that Hesse and NCLEX and all of those like to ask about because it has so many defects within one defect. Okay. So those TET spells she was talking about, so that's when they get hypercyanotic, so their cyanosis gets worse. So they're running around, they're using a lot of their oxygen in their muscles. Typically happens before like ages 2 and less, okay? So they will have spontaneous drop in their oxygen saturation. They'll become more distressed with the respiratory, their work of breathing, have more weakness, and they may even pass out, okay? Can last up to a few hours, potentially. And then they're gonna be really lethargic and really sleepy after these TET spells, because it's a huge demand on their body, on their heart, okay? So if you have a kiddo and having a TET spell, the first thing you do is push their knees up to their chest or have them squat down. Because then, like in that video, it talked about, then we reverse that resistance. We vasoconstrict and push that blood easier back to the lungs. Okay. Dextro position of the aorta is the same thing as overriding aorta. Okay, so when you see dextro position of aorta, that just means that that aorta is taking, it's positioned to take blood from both the right side and the left ventricle instead of the left ventricle like it should. Does that make sense? Are you guys all totally confused? Confused. Is that what you guys are saying? Yeah. So there's a lot of defects. Rewatch that video. That will help. Slow it down. You can pause it and take your notes. Okay. But really know tetralogy of flow, because like I said, this is the question that gets asked about the most on exams and HESI and NCLEX, because it has the pulmonary stenosis, has the right ventricular hypertrophy, the dextro position or overriding aorta, okay, and the VSD, so the ventricular septal defect. Okay. All right. Congestive heart failure. So these are your signs and symptoms of that. You guys can read this. So I'm not going to read this to you. Rheumatic fever. So that's something that goes along with strep throat if it's untreated. We kind of touched on this. Kids, though, with rheumatic fever, they can have cardiac involvement as well as their joints being involved in the inflammation. So these kids will have to be on antibiotic therapy, typically penicillin prevention, for at least 5 years after diagnosis of rheumatic fever. Okay. Sometimes if there's a lot of cardiac involvement, they can be up to 10 years potentially on the penicillin prophylaxis. Other treatments with rheumatic fever are anti-inflammatories, so your ibuprofen. Sometimes they will use aspirin. Now, typically we don't use aspirin in kids, right, because of Reye's syndrome. But in kids with rheumatic fever, sometimes aspirin will be utilized. You may also see these kids on steroids, okay? And obviously, if cardiac failure occurs because of rheumatic fever and strep going unnoticed, then that has to be managed as well. Here's your criteria for rheumatic fever diagnoses. You guys can look at that. Obviously, kids with cardiac defects are more at risk for hypertension. Okay, so we're going to treat them somewhat similarly as you guys treat adults. So dietary and lifestyle things first. Okay. In kids, they typically don't do blood pressure medications or other antihypertensives. But in kids with cardiac defects, it's more common to see them on antihypertensives. Okay. Even after they've been repaired, some of them. Okay. Kawasaki disease. This is our last couple slides. So this is something that happens can happen after, most commonly, strep, but it can also happen after a variety of viral illnesses. I've seen this happen after COVID, influenza. So they have to have a sustained abrupt onset of fever of 104 or as high as 104. So over 100.4 for 5 days. Okay. That fever typically doesn't get much better with using antipyretics. So, your fever reducing medications like Tylenol or ibuprofen. Okay. And it also doesn't get better if you give them an antibiotic. They're going to have conjunctivitis. So they're going to have these injected red, fiery looking eyes with no discharge. Okay. They're going to have cracked, fissured lips. Their tongue is literally going to look like a strawberry with these kids. Okay. So if you are like looking at a kiddo and they have red eyes with no discharge and they stick their tongue out at you and it looks like that, you're going to want to get a hold of the provider really quick. Okay. Also, they'll have enlarged, not painful lymph nodes, typically on their neck. You'll also see petechiae, which is teeny tiny little bruising in those capillaries. It's leakage from the capillaries, not blanchable. Okay, so when you push on those, they don't turn white, okay? And they are flat. Treatment for Kawasaki's disease is IV gamma globulin or IVIG, okay? This typically, your concern is that you're going to have coronary artery problems, typically dilation, increased coronary artery pathology. So as long as the IVIG is given very quickly, then you don't necessarily see the long-term effects of there being coronary artery pathologies. These kids will also be on aspirin. So like I said, this is another case where kids are on aspirin because of the risk of thrombosis after having Kawasaki's disease. The period of time varies depending on the kiddo and their significance defects. They may also wind up on warfarin if there are concerns for aneurysms in that coronary artery. Okay. Symptomatic supportive cares, plus you'll be doing the IVIG, potentially steroids or aspirin. Okay. Parents should be taught that they need to postpone their routine vaccines. It says for several months in your book. I would let the cardiologist decide that, but that's just because they were given IVIG. Okay. And also because they utilize steroids a lot of times in these kids. Compliance for any long-term medications in kids can be a struggle across the board, whether it's aspirin or an antihypertensive or what have you, but you really need to explain to these parents that they need to continue on aspirin even if they're feeling okay. Okay. All right. Questions? I know you guys all get very overwhelmed with cardiac stuff. It's hard. Okay. This last exam is tough. Okay. So if you need help, you want to meet with me to go over cardiac stuff more often, I would suggest using those videos, replaying them, pausing them. They have videos for that same lady has videos for every defect. So VSD, ASD, PDA, all of that. I think VSD, ASD, PDA is usually more easy for students to understand. But for the tetralogy of flow, knowing that stuff. Also in the PowerPoint, we didn't talk about hypoplastic left heart. So that's a poorly functioning left side of the heart. Know that as well. Okay.
What was that again?
Hypoplastic left heart syndrome. HLHS is the other, that's the other cyanotic lesion that we didn't talk about in the PowerPoint today, just for time's sake. Okay. But make sure you're looking at that as well. Use your study guide to help you. There will be a quiz next week over this material. Okay. You guys will be fine. I know you're all like way overwhelmed because you took your exams and then we did very hard content, but it'll be okay. But if you need me, let me know. Okay. Marquita, I saw your message. So if you just want to stay on, we'll chat really quick. Okay.
Me?
Yeah. Yeah. I saw your message here about one of the exam reviews. You had a question about it. So everyone else, though, you guys can hop off. But if you need anything else from me, you know how to get a hold of me. Email's easiest usually.
Thank you.
I have a question.
Yeah.